Welcome to ATCM, the Emergency Medicine channel. Today let us discuss about neutropenia and neutropenia related sepsis. We know that blood is produced in bone marrow from blood stem cells. Then it forms into myeloid stem cells and lymphoid stem cells. In myeloid stem cells, you can get RBCs, platelets and granulocytes. In granulocytes, we have eosinophils, basophils and neutrophils. Other side, lymphoblast, lymphoid tissue, lymphoblast, plasma cells, T lymphocytes, killer cells, so many other cells are formed, B lymphocytes, all these things are formed. So basically, there are different functions like RBC carry oxygen and other glucose, all these things. Platelets help in forming coagulation or prevents bleeding. Eosinophils have got eosinophils, basophils have got different actions, but neutrophils, if you take, the major action of neutrophil is to protect our body from various types of infections by producing inflammatory response against that pathogen. Sometimes it may be against a bacteria, virus or some other pathogen which can produce an illness. Sometimes there will be dysregulated mechanism and that produces immune mediated disorders. That is a different spectrum of the disease where lymphocytes, neutrophils all will be participating. So that is immune dysregulated syndromes like rheumatoid arthritis, SLE, all these things. But whereas in an infection, when there is an infection, these neutrophils will try to protect from that type of infections and it protects the body from these infections. So activated neutrophils will produce various actions against immune mediated injuries or infectious diseases. So here it can kill the bacteria, virus or fungus, like that. There are different mechanisms like phagocytosis or fibroblast, endothelial cells, dendritic cells, macrophages. Different types of cells are formed from these neutrophils and try to neutralize these pathogens in our body. So when the neutrophil counts are reduced, it produces reduction in our total body immunity. So there are three important mechanisms by which neutrophil count can reduce. We call it as neutropenia. Low neutrophil production from the bone marrow. It can be due to bone marrow failure, secondary to drug-induced problem, secondary to infections, secondary to nutritional deficiency like vitamin B12, folic acid and all, or it can be marrow infiltration. Second mechanism is redistribution of circulating neutrophils to the vascular endothelium. This is called as marginization. It can be that neutrophils can be destroyed in circulation or in spleen. Immune destruction, it can be drug-induced immune destruction or autoimmune diseases which produce destruction of RBCs, WBCs or platelets. Here if the WBCs are destructed by autoimmune diseases, then it can also produce deficiency in the neutrophil count. It can be categorized into three major groups: mild, moderate, severe. If absolute neutrophil count more than 1000 and less than 1500, it is mild. If it is more than 500 and less than 1000, it is moderate. If it is less than 500, it is severe. In severe neutropenia, another condition is agranulocytosis. Agranulocytosis means granulocytes are nil, where absolute neutrophil count can be less than 200. That is something like absolute deficiency of neutrophil. Even if it is less than 200, there is no actual function for this type of neutrophils because numbers are very, very low. So the defensive mechanism is absolutely zero. There are various causes for neutropenia. TB, typhoid, brucellosis, measles, infectious mononucleosis, viral hepatitis, leishmaniasis, many viral fevers, HIV, immune disorders like SLE, rheumatoid arthritis. Directly autoimmune neutropenia itself can present without any secondary diseases like SLE or RA. And invasion of bone marrow, myelofibrosis, nutritional deficiency like B12, folic acid, benign familial neutropenia, chronic benign neutropenia of childhood, chronic idiopathic neutropenia, neutropenia associated with metabolic disorders, neutropenia due to increased marginalization. So many disorders can reduce the neutrophil count in our blood. Now the drugs, if you take, main drugs are penicillamine, naproxen, that is an NSAID, chloroquine, antimalarial drug, methotrexate, anti-rheumatoid drug, carbamazole, propylthiouracil, antithyroid drugs, phenytoin, sodium valproate, carbamazepine, amitriptyline, all are anti-epileptic drugs, captopril, enalapril, nifedipine, antihypertensive drugs, and antibiotics like penicillin, cephalosporin, sulfadoxine, pyrimethamine, dapsone, zidovudine. So many drugs can produce neutropenia. So this list is not complete. There are many other drugs which can also produce neutropenia. Now there are something called as intrinsic defects. We will not go to that condition now because these conditions are very, very rare. But you should remember the names of these intrinsic conditions because they are rare conditions. If you are not getting any other cause for neutropenia, then these are the causes. But the commonest cause is always viral infection. So you see any viral fever, you can see the counts are slightly reduced. In some viral fever, it will be completely towards the lower side of the normal value. Now, clinically significant neutrophil counts more than 1500, it is taken as normal. Even when you have a neutrophil count 4000 to 11000, if it is less than 4000 also, patient may not have any clinical features because of neutropenia. So more than 1500, it is normal. 1000 to 1500, less chance for infection, but we have to be very careful. 500 to 1000, there is a possibility of infection. So this type of patients should be isolated. This is called as reverse isolation. Less than 500, high chance of infection, few clinical signs of infection can be present, and patient should be treated with IV antibiotic to prevent infection. Less than 200, the inflammatory process will be absent. This is a problem in neutropenic patients. So normally when we get some infection, we have fever, lymphadenopathy, hepatosplenomegaly. Like that, clinical features of infection will be there when our neutrophil counts are normal. But when the neutrophil counts are absolutely zero or reduced, there is no chance for inflammation. Infection is there, but against that infection, body is not trying to do anything because there is no inflammatory cells formed in the body. So inflammatory response is nil in this type of patients. So these patients may be clinically stable. So when the patient comes with infection, they may not have fever, they may not have toxicity, but when you are evaluating, you can see that the patient is having features of sepsis. So when we get a neutropenic patient in emergency room, we have to see whether the patient is ill or febrile. If the patient is ill or febrile, directly we can start antibiotic. Even otherwise, if the neutrophil counts are very, very low, we have to see to prevent infection, we have to give antibiotics. So when we are thinking about antibiotics, Pseudomonas is one of the most important problem in neutropenia. So we have to take care of that. So all patients who is having neutropenia, we have to evaluate for causes for neutropenia. You have to see whether any infections are there. We can see any B12 deficiency is there or not. Any drugs patient is taking which can produce bone marrow suppression, and ultimately, if we are not able to find out any cause, we have to do bone marrow study also. And many neutropenias, whether it is infection induced or drug induced, once that infection is over, bone marrow recovery is fast. So bone marrow study is the gold standard study in neutropenia, which is not getting corrected within 1 or 2 weeks, because most of the infections within 1 week, most of the viral infections within 1 week the bone marrow recovery can occur, but bacterial infection after treatment bone marrow recovery can occur. But in tuberculosis and all, there may be chance, there can be chance of permanent damage to bone marrow, so we have to be very careful. Some chronic infection, chronic inflammation, permanent bone marrow damage can occur. So in all these conditions where the patient is not recovering from neutropenia, we have to always go for a bone marrow study. Bone marrow neutrophil production is considered to be adequate if the cellularity and maturation of the neutrophil series is normal or increased. Reduced bone marrow cellularity or myeloid arrest at the myelocyte or metamyelocyte stage indicates decreased bone marrow ability. So we have to do the bone marrow and see whether the response is increased or response is reduced. If there is a peripheral destruction of WBC, then bone marrow production will be more. If the bone marrow itself is having problem, then the production will be very, very low. Sometimes you can see myelofibrosis or hot spots, various things are there in bone marrow study, but we will not be discussing all this now. Now, once you diagnose neutropenia in emergency room or in ICU, we have to evaluate the cause for the neutropenia. If there is an offending drug, stop it. If there is an infection, if it is a viral infection, give some time to recovery. If it is a bacterial infection, always try to treat the patient with antibiotic. But we have to prevent infection. If the neutrophil counts are very, very low, less than 500 and all, we have to try to prevent the infection. So oral hygiene maintenance is very, very important. Oral antifungal agents, chlorhexidine mouthwash has to be given, because that is a focus of infection in many patients. We can give Bactrim DS, that is trimethoprim sulfamethoxazole tablet, double strength tablet can be given, BD, Bactrim DS BD. Whenever patient come with sepsis, high degree fever, hypotension, all these things, we have to think about severe infection due to organism like Pseudomonas, MRSA, methicillin resistant Staphylococcal aureus. So we have to prevent these infections. If the patient is not having infectious problem, and if the counts are very, very low, we have to give preventive antibiotic. Ceftazidime is one of the most important drug which can prevent Pseudomonas infection. But if there is an infection, then go for a higher antibiotic like piperacillin tazobactam. Vancomycin is given to cover the MRSA. And we can give even colony stimulating factor. Colony stimulating factors are mainly useful in drug-induced neutropenia. So we can give filgrastim 5 microgram per kg per day subcutaneous infection. This is mainly given in drug-induced neutropenia. So we can give for 14 days, up to 14 days we can give, and continue until the absolute neutrophil count more than 10,000. So we can continue the colony stimulating factor, which try to increase the production of bone marrow production, so it can maintain the levels of neutropenia in a neutropenic patient. But this is mainly useful in drug-induced neutropenia. Other neutropenias, the response is not very good, and in patients who is having leukemias with neutropenia, try to some time during the treatment, sometimes patient can develop neutropenia. In that type of patients, we have to be very careful in using this drug, and it is not recommended also there. So febrile neutropenia, counts has to be taken, blood culture has to be taken, at least 2 blood cultures from different sites has to be taken. We have to document any infection, we have to think about fungal infection, opportunistic infection, and always try to treat for Pseudomonas and MRSA. For Pseudomonas, we can give ceftazidime or piperacillin tazobactam. For other MRSA, we can give vancomycin. Then PCP pneumonia prevention, we can give Bactrim DS, and antifungal medication also should be given in some patients who is not responding to antibiotics. So these are the basic things we have to give from emergency room. And whenever patient is having neutropenia and not having infection at the time of admission, we have to always do reverse isolation for the patient. Reverse isolation means patient is isolated from other patients, because this patient is prone to get infection from other patients, so they have to be isolated from other patients. So we have discussed about neutropenia, one of the important clinical problem in emergency room, especially when we have a large cancer unit, because many patients who is having malignancy, they can have neutropenia either because of drug induced neutropenia or by a malignancy induced neutropenia, or by infiltration of bone marrow by cancer cells. So these type of problems are very common in cancer center, mainly in cancer center associated hospital. So these patients can present with neutropenia or neutropenia induced infections, so we have to be very careful when we are dealing this type of patients. Reverse isolation, ceftazidime or piperacillin tazobactam for infections like Pseudomonas, vancomycin for MRSA, then Bactrim DS, that is sulfa drug to prevent PCP infections, antifungal medication. All these things should be given. Oral hygiene is also very important in this type of patients. Thank you.